Hello, everyone. Today we'll be exploring evidence-based approaches to suicide prevention and crisis intervention. This is a challenging but important topic for all professionals. By the end of this presentation, you'll be able to identify and apply evidence-based suicide prevention strategies, locate crisis resources, conduct trauma-informed assessments, understand your reporting obligations, and match appropriate trauma modalities to client needs. These objectives align with the best practices in suicidology and crisis intervention. In 2023, over 12 million adults had serious thoughts of suicide. There were at least 1.5 million attempts, and nearly 50,000 Americans died by suicide. Suicide is the second leading cause of death of young people, ages 10 to 34. And it's also important to note that about 90% of people who die by suicide have diagnosable mental health conditions. This means that we as professionals have opportunities to intervene, to provide treatment, and save lives. What works to prevent suicide? Well, the CDC notes 7 major prevention strategies and research supports. One being strengthening economic supports. For example, improving housing, financial security, and improving household financial security and stabilizing housing. Why this matters. Economic stressors often increase risk, so reducing those stressors builds protection. Create protective environments. This means reducing access to lethal means of harm, shaping safe organizational culture, and reducing substance use. When the environment is safer, meaning less easy to access lethal means and such, suicide risk decreases. Improve access to and delivery of suicide care. This means making sure mental health conditions are covered by insurance policies, increase provider availability in underserved area, and create rapid and remote access. Gaps in treatment access are major risk factors. Improving access equals better prevention and more effective recovery. Promote healthy connections, meaning peer support programs, community engagement, and reducing isolation. Strong social ties and connections act as protective factors against suicide. Teach coping skills and problem-solving skills. Social emotional learning for adults, or for youth, and parenting skills for adults. Resilience education. When people have better coping skills and ways to problem solve, they are better able to manage crisis and stress without suicide behavior. Identify and support people at risk. Being trained in suicide prevention models such as SAFE-T and QPR, which we'll discuss shortly, post-crisis follow-up, and therapeutic interventions. Early identification and quick support can make significant differences. Lessen harms and prevents future risk. Postvention after a suicide, safer messaging about suicide, and media guidelines. After a suicidal event, attempt, or death, the risk for others or for reattempts is higher. This strategy aims to reduce the ripple effect. Some interventional models that can be useful, as we talked about in the previous slide, SAFE-T and QPR. SAFE-T, which stands for Suicide Assessment 5-Step Evaluation and Triage, is primarily used by clinicians. It provides a clear structure for assessing and managing suicide risk. First, identify risk factors. This means recognizing what increases a person's vulnerability, such as things like prior attempts, trauma, or access to lethal means. Identify protective factors. These are the buffers that keep someone safe, like supportive relationships, coping skills, or spiritual beliefs. Conduct a suicide inquiry. This is where we ask compassionate, direct questions about thoughts, plans, and intent. The fourth step is determine risk level and interventions, integrating what we've learned to decide whether the person is at low, moderate, or high risk and what action we might need to take. And finally, document and follow up. Because suicide risk isn't static, reassessment of our client should happen regularly. And documentation is also important to show that you followed the correct legal protocols. Next is QPR, which stands for question, persuade, and refer. It's simple, fast, and can be used by anyone: teachers, friends, coworkers, family. The first step is to question. Ask directly about suicide, even if it feels uncomfortable. Research shows asking directly can reduce distress and save lives. Next, persuade. Express concern, offer hope, and listen without judgment. Sometimes just hearing, "I'm glad you told me," can be life-saving. And finally, refer. Help the person connect to immediate support like 988, the local crisis line, or a mental health provider. While SAFE-T provides a professional clinical framework, QPC empowers people within the community to act early, before a crisis escalates. Together, these models demonstrate that suicide prevention is everyone's responsibility, from the clinician's office to the classroom to the dinner table. We can all make a difference and save lives. The CSSRS, or the Columbia Suicide Severity Rating Scale, is considered the gold standard in suicide risk assessment. It's free, evidence-based, and takes just 5 to 10 minutes to complete. It assesses ideation severity on a 5-point scale. Level 1 reflects passive suicide ideation, where a person wishes that they were dead but has no desire to actively harm themselves. For example, a client might say, "I don't want to wake up tomorrow," or "Life would be easier if I just disappeared." Level 2 involves non-specific active thoughts about suicide without a method or plan. This might sound like, "Sometimes I think about ending it all," but when asked how, they respond, "I don't know, I haven't really thought about the details." Level 3 occurs when someone has considered a specific method, but still has no actionable plan for intent. For example, "I've thought about taking pills because they're at home, but I don't think I'd actually do it." Level 4 indicates active ideation, with some intent to act, even if the plan is not fully developed. The person may say, "I think I may take all of my medication tonight. I'm just tired of everything," showing emotional readiness and increased risk. Level 5 is the highest level of risk, where someone has a clear plan, access to means, and intent to follow through. For instance, "Tonight, after everyone leaves, I'm going to take the pills I've been saving. I've already written letters." Notice the progression. This helps us adjust our level of intervention. Someone at level 1 needs support and monitoring, but someone at level 5 may need hospitalization. Safety planning intervention is one of the most important tools in our crisis intervention toolkit. Developed by Stanley and Brown, this is a brief, evidence-based intervention that helps clients recognize they are heading for or are in crisis, tools that can help, and resource for support. Step 1 helps clients recognize their personal warning signs. 2 identifies things they can do alone to cope. 3 moves to social settings for distraction. 4 involves contacting supportive people. 5 brings in professionals if needed. And 6 addresses lethal means restriction. This is not a no suicide contract. No suicide contracts have no evidence base and have been shown to be ineffective overall. The safety plan, however, is collaborative, specific, and research has shown it to reduce suicidal behavior by up to 50%. Some resources that we can inform our clients of. Starting at the national level, we have 988, which is the new Suicide and Crisis Lifeline started in 2022. It provides 24-hour support in English and Spanish with interpretations in over 150 other languages. The Crisis Text Line provides support via text, which is especially valuable for younger people and those who prefer texting to talking. And the Veterans Crisis Line provides specialized support for our military members and veterans who face unique challenges. If you're in Washington State, as I am, the Volunteers of America Care Crisis Line is your go-to number for 24/7 crisis services. This line can dispatch mobile crisis teams, arrange crisis triage center admissions, and provide immediate telephone support. The Washington Recovery Helpline specifically addresses substance use concerns, which often co-occur with suicidal ideation and other crisis situations. And lastly, dialing 211 connects you to a comprehensive database of community resources. This is important. It is important to have all these numbers readily available when someone is in crisis. You don't want to be searching for contact information during that time. Some of the very local services in my area of Snohomish County, we are fortunate to have a really robust selection. The Mobile Crisis Outreach Team provides face-to-face response in the community. They'll go to clients' homes, schools, or wherever they're needed. And the Crisis Triage Center offers voluntary short-term stabilization for adults and youth. And then Compass Health is our community mental health center, offering sliding scale services. All of these are accessed through the Volunteers of America crisis line we just discussed above. Trauma-informed care. SAMHSA outlines 6 principles of trauma-informed care that should guide all our interactions with suicidal clients. Why? Because the vast majorities of individuals in crisis have experienced significant trauma. Our approach can either make things worse or promote healing. The 6 principles, as outlined by SAMHSA, are safety, meaning both physical and emotional safety; trustworthiness, being transparent and consistent; peer support, recognizing the power of shared experiences; collaboration, meaning we share power and decision-making with clients; empowerment, focusing on strengths and resilience; and cultural sensitivity, understanding the historical and cultural context of the event and the responses of the client. When working with suicidal clients, you should ask yourself, is my approach trauma-informed? Am I creating safety? Am I building trust? Am I collaborating rather than dictating? These principles are essential for effective crisis intervention. The connection between suicide and trauma. Trauma and suicidality are often connected. Research consistently shows that childhood trauma increases suicide risk 2 to 5 times. ACEs, the adverse childhood experiences, show a dose-response relationship, meaning that the more ACEs someone has, the higher their risk. PTSD diagnosis also increase suicide risk 6-fold, and recent trauma can precipitate an immediate crisis. When assessing suicidal clients, we need to screen for trauma. Ask questions like, have you experienced any traumatic events in your life? When did you first start having suicidal thoughts? What was happening then? Do memories or reminders trigger your suicidal thoughts? It's important to get general information when we screen for trauma during the crisis, but we don't want to deep dive into processing it just yet. That comes when the client is more stable. In immediate crisis, our focus is on safety first and foremost. Recognizing and reporting abuse. As mental health providers, we are also mandated reporters. This means we must be vigilant for signs of abuse and neglect, which include physical, behavioral, and emotional signs. Some of the physical signs might include unexplained injuries, especially in various stages of healing, poor hygiene, or untreated medical conditions. Behavioral signs might be fearfulness, withdrawal, or age-inappropriate sexual knowledge. Emotional signs include low self-esteem, difficulty trusting, self-harm, or suicide ideation. We can also look to caregiver behaviors, like providing inconsistent explanations, showing little concern, or isolating the individual. While one sign doesn't confirm abuse, clusters of them warrant further inquiry and potentially reporting. Trust your judgment. If something feels off, it probably is. In Washington state, all mental health professionals are mandated reporters for child abuse and neglect, as well as vulnerable adult abuse. The standard is reasonable belief. You don't need proof. That's CPS or APS's job to investigate. For child abuse, call 1-866-END-HARM. For adult protective services, call 1-877-734-6277. Of course, if there is an immediate danger, call 911 first. When you make a report, provide your name, contact information, victim's information, nature and extent of the suspected abuse, and any other relevant observations. For non-emergency situations, report within 48 hours, and for imminent danger, report immediately. Good faith reporters have immunity from civil and criminal liability. Failure to report, however, can result in legal consequences. Always document when you make your report, who you spoke with, and any follow-up. Reporting can feel uncomfortable, especially if it affects the therapeutic relationship, but protecting our clients is one of our highest duties. It's not your job to investigate, but it is your job to report. Once the person is stabilized, it will be important to work from a modality that is aligned with trauma recovery and supports the client's situation best. Dialectical behavioral therapy, DBT, and eye movement desensitization and reprocessing, EMDR, are evidence-based trauma modalities appropriate for suicidal and traumatized clients. DBT was specifically developed for chronically suicidal individuals with borderline personality disorder. It has 4 core modules: mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. The evidence for DBT reducing suicidal behavior is extremely strong. DBT skills such as grounding and breathing exercises might be taught and used on the spot during a crisis to help stabilize someone. However, many of the other skills should be used in counseling after stabilization to help prevent further suicidal episodes. EMDR is a World Health Organization endorsed treatment for PTSD. It uses bilateral stimulation to help the brain process traumatic memories. It works well for single incident trauma, complex trauma, and suicidal and suicide that stems from trauma. Suicidal thoughts that stem from trauma. Note that clients must be stabilized before you begin trauma processing. If they're in acute crisis, EMDR is not recommended. Stabilize first, then address the underlying trauma. Some other modalities are cognitive processing therapy, CPT. It's also effective for PTSD and the cognitive distortions related to trauma. It helps clients challenge and modify their maladaptive beliefs about the trauma. It has strong empirical support, especially for assault survivors. For example, a therapist might help a client challenge the belief that the trauma was their fault by examining evidence for and against the thought, exploring how they would view the situation if it happened to someone else, and recognizing natural trauma responses like freezing. Through guided questioning, the client shifts from self-blame to a more accurate and compassionate belief. They reacted the only way they could at the time, and the event was not their fault. Trauma-focused CBT is especially useful for children and teens who have experienced trauma. The PRACTICE acronym stands for Psychoeducation and Parenting Skills, providing information about trauma and teaching parents and children skills to help the child. Relaxation skills, teaching the child self-regulation and relaxation techniques. Effective expression and modulation, helping the child identify and express and manage emotions. Cognitive coping skills, helping the child reframe unhelpful thoughts by understanding the connection between thoughts, feelings, and behaviors. Trauma narration and processing, helping the child tell the story of what happened in a safe and structured way. In vivo mastery, gradually addressing avoidance behaviors and developing a plan for desensitization to trauma reminders. Conjoint trauma narration, sharing the trauma narrative in a session with a supportive caregiver. And finally, enhancing safety and future development, focusing on improving safety, empowerment, and self-esteem for the future. The key principle across all these modalities is stabilize before you traumatize. Make sure clients have coping skills and safety before diving into trauma work. Now it's your turn. I've included a safety plan template in the handouts that support this presentation. I want you to complete on your own your personal safety plan. Pause this video and take 5 minutes to complete your plan. Be honest with yourself. Step 1, identify your warning signs. What are the earliest warning signs I'm beginning to struggle? What thoughts, feelings, and physical sensations show up? What situations or triggers tend to make things worse? What behaviors do I notice when I'm heading into crisis? Step 2, internal coping strategies. What can I do on my own to calm down and distract myself? What activities help me feel grounded and soothed? Step 3, people and places for distraction. Who or where helps shift my focus and lighten my mood? Who can I spend time with casually when I need company? Are there safe public spaces that I can go to feel less alone? Step 4, people I can ask for help. Who can I reach out to when I really need support? Who listens without judgment, and who can stay calm with me? Who has helped me during difficult times before? Who could I text or call if crisis symptoms escalate? Step 5, professional and crisis contacts. Who can I reach out to for immediate professional support? What therapists, doctors, or case managers can I contact? What crisis lines or emergency resources can I use? Step 6, making the environment safe. How can I reduce access to anything that could be used to harm myself? Are there medications, weapons, or items I should remove from lockup or lock up? Who can help me store or secure things safely if needed? Protective factors or reasons to live. What makes life meaningful and worth holding on for? Who or what do I deeply care about? What future goals, hopes, and dreams matter to me? What values, strengths, and personal commitments keep me going? When you have completed your plan, reflect on this experience. What was easy to complete? What was hard? What did you learn about your own support system? Hopefully this helps you better understand what clients might be experiencing. Maybe you realize that you don't have as many coping strategies as you thought you did. Maybe you struggled to identify people you could call. Maybe you felt vulnerable. Your clients felt all these things too. A safety plan matters because crises make it hard to think clearly. And when someone feels overwhelmed, having a written step-by-step guide can literally save someone's life. To be effective, it needs to be simple, personalized, and accessible. This means keeping it where it can quickly be reached on your phone, in your wallet, by your bedside, saved as a screenshot somewhere. The goal is not to have a plan somewhere, but to have it available the moment you need support. The key takeaways. In summary, prevention is possible using evidence-based models like SAFE-T, QPR, and safety planning. Trauma-informed care is essential. Most suicidal clients have traumatic histories. Know your resources, 988, the VOA Care Crisis Line, and mobile crisis teams. Use structured assessments like CSSRS, and always follow with action. Understand your mandated reporting requirements in your state. And lastly, match your treatment modality to your client's needs, but always stabilize before processing trauma. All of these resources we discussed today are available in submitted handouts that accompany this presentation. I encourage you to bookmark these websites, save these numbers in your phone, and explore training opportunities. Thank you for your attention to this important topic, and remember, working with suicidal clients is emotionally draining. Take care of yourselves. Practice what you preach. Use your own coping skills. Seek supervision and prioritize your well-being so that you will be able to continue helping others. Thank you.